And to a much lesser extent, our circles are much smaller in Africa and in other parts of the world which we consider low and middle income countries. So I want to focus a little bit on sub-Saharan Africa and really ask the question of all of you and get some thoughts as to what's going on now, what's going on that we're not seeing, and what we can expect to see in the future, and what kinds of responses are available to us to sort of think about what to do about that. We've heard already today a very nice talk about introductions to Africa from China, and increasingly introductions from other hotspots. So it's not just travelers from China, although that was what was modeled. There's been a fair number of introductions in northern, the northern parts of Africa from Europe. So a couple of the early cases in some of the North African sites have come from France. So we do know that the epidemic in Africa is probably much later than in other places, partly because the mobility is less and from China during the peak of the epidemic there. And the travel in general to especially sub-Saharan Africa is, while it's pretty brisk, it's much less than travel between Europe, the US, and China. But these numbers may not just reflect I'm going to go back to this graph. These numbers probably don't just reflect late introductions. They probably also reflect the lack of testing that's available. One of the ways to think about whether COVID has been in Africa for longer than we've realized is to look at syndromic surveillance for flu-like syndromes. That relies in general on the collection of health management and information systems data from the countries affected. And while that exists, it's a little bit hard to assemble. So while in general, people are not reporting early, say December, January rises in syndromic flu cases, it's certainly possible that we're missing that. There's also the issue within Africa of a huge amount of internal and within country mobility that is difficult to control because of unmanned borders where there's really porous spread of people across country lines. So I'm just going to list a couple of other things, and I just want to try to have a conversation about them. I'm thinking here in this slide mostly about transmission. I'm going to come to the question of disease severity in a moment. So introductions from China, lack of testing, internal mobility. There's also the issue of population density. So Africa is home to some very, very big cities, but it's also the home to some very less densely populated areas. And it's hard at this point to speculate about how transmission is going to be different in LMICs compared to developed countries, partly because we know that there's a lot of differences not only in population density, but in household and contact structures where it's probable and reasonably well documented that households include age range that is broader than the households at least in Europe and the US. And also, we need to think about the possibilities for social distancing and physical distancing in this region, where the economy is dominated by small traders, where people go to the market, very crowded markets on a daily basis to get food and supplies, and where the kinds of things that we might put into place in the US and Europe and China in terms of social distancing would really create hardships that are very different from the hardships that people are feeling today in the US. So those social and economic pressures really may prevent the possibilities of the kind of social distancing that we think has been effective in other countries. And then I want to switch the gears. We want to start the conversation about transmission and then switch to what about disease severity. There's we really focused so far on the age distribution and the frequency of coronary vascular disease. And we can assume that will give sub-Saharan Africa some advantage. Here's the population distribution in Africa, the US, and China, where 51% of the population in Africa is under age 20, with 25% in the US and 23% in China. Europe, it's even lower. Furthermore, the prevalence of coronary vascular disease is much lower, at least as far as we know, in Africa, but it's many of the cases are untreated or undetected, so that we have that disadvantage as well. And then finally, I want to spend a little bit of time on obviously the capacity constraints, which are extreme, and then what kinds of opportunities we think might be specific to this environment. So let me go back up to transmission and open this to discussion and try to get some ideas about what other people on the line think are going to be relevant to the differences in transmission in low and middle income countries, and particularly in sub-Saharan Africa. I'm trying to make sure I can see you all, so I can try to figure out how to call on you, but at the moment I only see a small number of you. So I think if you just unmute yourself, and as long as we're not all talking at once, or you can send me a message, I can call on people.
I might try to start out if that's possible.
Please.
I'm Tom Bossert. I'm not anywhere near an epidemiologist, but I've been asked by a think tank in El Salvador to help them develop a national plan. And one of the things that I've been thinking about is they're not likely to have the testing that's necessary to do the kind of analysis of what they have. But David Canning and David Bloom published a short piece on how to do surveys that might help understand, with a limited number of testing and a series of questions to be asked, that could be used in low-income countries, because obviously they're not going to, if we don't have the ability to get the tests that we need, those countries are going to have a hard time getting those. And I just wonder what other people think about using that kind of an approach to help people understand what the disease pattern is at any point in time, and how to use that in modeling that they might use.
Let me just ask a quick question. So I'm not familiar with the paper. Is that a survey of syndromic, looking for symptoms of disease, as opposed to, say, actually testing?
I think it was a limited number of cases that they could do tests on, and also ask about symptoms and other things. So it was designed for New York. It's a way of trying to assess without having to do full population coverage. So I guess in trying to interpret that for doing it in a less developed country would be, if you can get enough tests to do antibody testing or any of the other kinds of testing, would this survey method, rather than trying to follow each case and try to do massive testing, how do epidemiologists view that as an alternative?
There's many epidemiologists on the line. Can I look to them to answer that question, or try to?
Yeah, good afternoon. Here on the faculty at Global Health. I'm not going to try to answer it, but let me just say a few words about what I have been hearing from my own circle of colleagues in various places, which is that for that type of survey to be helpful, it has to be done fairly with a large number of people and fairly frequently. So I know in the UK there's been talks about 1,000 people every week, and that's still a high cost. So I'm wondering if El Salvador or our countries I work with in Tanzania, Uganda, anybody has the capacity to do that. One thing that has been circulated, again, it's just an idea, is what if we have enough information about the case fatality rates, can you back calculate prevalence based on death rates? But even that is tricky because at least based on some anecdotal evidence from Iran and elsewhere, there is also a stigma associated with COVID-19 deaths. So there might be underestimation of the number of deaths, and the overall average 1% case fatality that we have is also uncertain. So one part of me thinks, what would we do with the results of that survey? So I have, again, anecdotal evidence from our colleagues in Uganda and Tanzania that it's spreading. So what I've been telling them is we have to get the sort of public health system, whatever there is, to be ready for what's coming their way, from public health transmission, then to severity and to cases in hospitals, and they're nowhere ready for it. So it's at this point, it's very scary for me.
Yeah, it seems to me that one of the things when we're designing these surveys that we sometimes miss is what specifically is the objective? What are we trying to achieve? So it's one thing to try to plan, and that will be very useful for us to know both what proportion of the population is already immune, which will give us a great sense of where we are in the epidemic curve, which I think we really don't know. I mean, we're beginning to find it out for Europe. Probably we'll find it out eventually for the US. China, I understand, is in the process of doing a seroprevalence study in Wuhan. But that's very hard to implement in many parts of Africa, especially without testing available. So by that I mean antibody testing. But if we're going to do these large population-based surveillance studies, we really need to know exactly what we're going to do with the data. One of the constraints here is that, you know, we want to use this data to plan, but we're so far under capacity for any outbreak in most countries in Africa that the subtleties of whether we're planning for hundreds of thousands versus tens of thousands of cases in particular countries are kind of irrelevant, because we just don't, at the moment, we don't have the capacity to meet even a small caseload. Other thoughts?
So this is Guy Harling. If I can just make a suggestion. I've heard of some work being done, sorry about the background noise, some work being done or presented around the idea of shielding populations who are vulnerable, not necessarily at the individual or even the household level, but beyond that. And I wonder if the idea of trying to make some kind of plan around sort of risk assessment and protection at those kinds of levels might be more applicable than trying to take more lockdown approaches we've seen in higher income settings.
So Guy, let me ask you, I think one of the things that comes up a lot is, you know, we know who we think is vulnerable in our own country, in China and Europe. We think that elderly people with coronary vascular disease, but we really haven't yet established the role of HIV, other kinds of immunosuppression, chronic infectious diseases, malnutrition. So until we have that data, how would we, other than, you know, looking at the risk factors that we already know about, how would we identify which populations we think are at highest risk?
So can I say I don't know? But
of course.
There was a presentation earlier on by, I forgot the name of the gentleman, about risk factors in looking at social determinants as risk factors. And I think I'm aware that within South Africa, where I've done most of my work at the moment, there is a focus on high-risk communities based on a range of factors. And it's not necessarily deeply based in COVID per se, but based on what we know about risk factors for infection and progression in general. And I wonder if that's maybe a best guess starting point, which we can update when and as we know what HIV, TB, malnutrition, all these other things look like.
Yeah. So there's a couple of comments coming in on the chat line. I'm sorry if my friend here is bothering anybody. That's my dog, Edgar. So there's a question about the role of nutrition on disease severity. As far as I know, there's been there's evidence that overnutrition, that obesity is malnutrition that in the form of obesity is a risk factor in China and probably in the U.S. Probably related to the frequency of coronary vascular disease in people who are obese. But I haven't seen data on low nutrition or micronutrient deficiencies. One could imagine that vitamin A deficiency is associated with some other infectious disease outcomes, viral disease outcomes, that might be a factor. Does anybody else know of data on malnutrition or micronutrient deficiencies that has emerged from the last couple of months of research?
Megan, this is Sachit. Not yet, but I think if any data coming from India that are reliable are likely to be from the state of Kerala, and they've been doing a decent job collecting data. However, Kerala is an anomaly and may not have the high rates of malnutrition you see elsewhere in India, just because of the high literacy rates and really good public health measures. Just building on sort of what you're exploring in this discussion, the percentage of elderly are much smaller. Just the age pyramids are constructed differently in all these LMICs compared to where we initially got data from. And I think the concern, of course, is the lockdown of tens and hundreds of millions of people. In that scenario, how might or should these countries be thinking of herd immunity? At some point, they'll start seeing deaths or really heightened morbidity just from the starvation that the economic lockdown is creating in these informal economies. And so, do you then just say protect the vulnerable? And of course, your question was, look, we don't even know who the vulnerable are in these countries. It may not be as simple as just the elderly or the undiagnosed, non-communicable diseases. Just your thoughts on what alternative strategies are worth looking at. Is herd immunity even going to be a thing? How long does immunity last based on what Mark just said this morning, etc.?
Yeah. So let me, I don't know the answers to those questions, and we really don't know much about herd immunity. We don't know much about seasonality and how that might be affected in sub-Saharan Africa and other countries. We did have a conversation with some of the people at the Ministry of Health in Mali when they asked for some assistance from a group that I work with. And one of their points, which was really startling to me, was that they just really felt that any kind of social distancing measures were going to have such a strong effect on the immediate economic status of individuals that they couldn't put those into place. So specifically talking about how people really rely on food from markets on a daily basis, and that the cash available to buy the food is coming in on a daily basis. So if they put the kinds of lockdown measures in place, there would be immediate fallout from people who didn't have access to food, and would make a lot of current medical issues much worse. So I think it's going to be, there's already a big debate in the US about the trade-off between the public health advantages of lockdown versus the economic advantages. But the immediate connection between public health and economic status in Africa is much more obvious, I think. I lost you for a moment.
Thank
there.
you. No, I
Yeah.
just thanks.
Anybody else have some thoughts about what how to deal with this particular issue of how the lockdowns or social distancing measures will really impact different areas with much more economically vulnerable populations?
Here, I'm from Argentina, but I'm in Brazil. Apparently in Argentina, the focus has been on, let's say, the more, the poorer communities to basically do lockdowns at the neighborhood level, assuming that richer people or essentially higher class people are where at least so far, the outbreak is concentrated, and trying to keep basically the people's in the term ghetto has been used maybe in the double meaning of protecting from inside but also from outside, and trying to keep them inside of the neighborhood as much as possible, because it is understood that it is not possible to have any kind of housing isolation because of the conditions. 8 people living in 2 rooms, and it would be particularly common. So the unit of the lockdown is, let's say, the neighborhood in Argentina, and that is in some cases being thought about also for here in Brazil and in the favelas. So it isn't clear how possible that is or how viable that would be, but a lot of focus on trying to provide essentially food to people in that condition, because these are essentially people who live day to day from informal work in which they get paid for the work on the day. So every single day in lockdown means they are not able to. And also another problem, they apparently purchase food several times a day, in the sense that they are not able to stock up as in other contexts. So this inability to stock up means that they cannot do normal social distancing, let's call it, or quote unquote normal social distancing, purchasing monthly or weekly. So the supply of, specifically the supply of primary goods like food is very crucial because of this dynamic of this economic dynamic, this geographic dynamic. So that's what they're focusing on. And again, in Argentina, it seems to be that the focus is on trying to contain the spread within those providing those services or having the direct contact with those populations. So, for example, the police are working in monthly shifts, essentially. And that way, if you have an outbreak within the police force, it is contained to only a section of the police force, which would be in contact with these populations. So that kind of thing. I don't know if that's useful.
Yeah, so I work closely with a group in Lima in Peru, which is, actually a high middle income country. But a significant portion of people who live in Lima are without electricity and when running water or sanitation. It's a city of about 13 million people, of which about 1 to 2 million are actually well off, and pretty much everybody else lives in poverty. So, thinking about places which are very crowded, but at the same time are quite, they're neighborhoods that are quite inaccessible to cars, to transportation, without water, without refrigeration to store food, and even without sanitation. So we don't talk much about whether there's a fecal oral transmission route, because in most of the countries where we've seen COVID-19, even if there was, it would probably not play a major role. But in places where there's no routine collection of sewage, we really might start to see sewage being a route of transmission in very crowded settings. So other than actually providing food, water, sanitation, to neighborhoods that are locked down, I'm not really sure how these things can be addressed. The only country I know of that is trying to directly provide these services to everyone who's in lockdown is Rwanda. I don't actually know how successful it's been, but if anybody does know, that would be and it's an interesting model that if you're going to lock down a neighborhood, that you actually bring in food, bring in water tanks, but then try to arrange, the delivery of those so that people aren't in too much contact. Does anybody know of other attempts by either governments or non-governmental groups to do social support of lockdown communities?
Godard's here. I was going to mention actually the other side of the story, which is governments have, especially in the eastern part of sub-Saharan Africa that I'm more working on, have much more limited both capacity physically and also leverage sometimes on the populations to enforce, and how important other authorities are, including religious and ethnic in Africa. So if there is anything maybe to be gained from those, I think that might be a major difference between controlling this in Europe and Northern America versus Sub-Saharan Africa.
Yeah. One thing that's come up a number of times is the frequency with which people, the population in parts of Africa attend group religious services. So something like 85% of the population goes to some kind of religious meeting. And of course, we've seen from other countries that can be a place where transmission occurs. So there's been a call for engaging religious leaders in these kinds of decision-making processes, but that's a very challenging proposition. And we've obviously seen from Ebola in the DRC that it's not always the case that the communities are all that responsive to the government recommendations for how they should be living their lives. I would love to hear if there's someone in the audience who actually has direct experience of what's going on in either South Africa or other places where we're beginning to see cases in Africa. It would be great to hear your input.
If there are none, let me share indirectly messages from my colleagues in Uganda. I direct the Lana Scholars program, so I'm in contact with them in the past 2 weeks. So, for example, one of our colleagues, a cardiologist from Barara, shared this sort of feeling that so they have announced lockdown in major cities, but the population is in no way on board with that. And as a cardiologist, he had particularly high fears about taking care of their own patients, because now, I don't know, a diabetes patient or a severe hypertension patient, uncontrolled hypertensive patient, etc., they are asked to sit at home and not go to their usual services, and they're trying to sort of get ready and divert services. The country, I'm told, had initial cases imported from Dubai, possibly, which wasn't mentioned in the morning, so I was surprised. So major hubs, and I guess are those kind of places. But the first initial 8 cases disobeyed the quarantine, which again goes back to the comment I had about rule of law in some of these places. So that's what I'm hearing. In Tanzania, I've been in contact with initial cases now, and some communities have not seen anything, but they are still sort of worried about the spread, of course.
Thank you. So one thing we haven't mentioned is something that happened during the Ebola epidemic, which is that the mortality from other diseases rose. In Sierra Leone, for example, maternal mortality rose significantly. And there are probably two reasons for that. One was because people were afraid to use medical services where transmission was clearly happening. And then the other was just the quality of medical care that could be provided in the context of medical services being overwhelmed. So particularly, you know, I mean, one issue that someone has brought up on the chat is that in the absence of having the capacity to isolate patients who are in intensive care, first of all, there's probably in many places there isn't going to be any intensive care and ventilated beds to speak of. So are we actually increasing infection risk by whatever kind of care we can provide by having people come into hospitals? So, and what would be the alternatives? To designate specific units as they did during Ebola, but then being sent to an Ebola treatment unit, especially without a diagnosis of Ebola, was a death sentence. So, you know, there's a perception piece that if you go to a facility, you may be put at more risk. And then there's the actual, just the overwhelming of services. Another issue that's specific, I think, to a lot of LMICs is the role of community health workers. So, you know, unlike Europe and the US, there really are some very good networks of community health workers in many African countries where community health workers are attached to particular households and do systematic follow-up over time. The question is that that would be a very useful way of doing things like syndromic surveillance, or if we do get antibody tests to the community, to doing those kinds of serosurveillance. But it's also possible that having individuals who might not have access to protective equipment going from household to household to household is a very effective way of spreading disease. So be very curious to know what people's thoughts about the role of community health workers in this response.
Megan, this is Sachit again from India. You know, currently exactly the opposite is happening, right? Because of the complete lockdown, the community health workers cannot do what they're doing. And so, you know, vaccination programs are being delayed, critical care for malnutrition programs, like all of that is suspended. So as you said, we'll see sort of these long tails of morbidity and mortality long after, you know, the COVID peak is done. And you're totally right? Like the utilization of community health workers for both messaging as well as testing and surveillance will be very important, but they are not considered essential services yet, you know, until I think there is more noise both in the literature as well as in popular media about how they should also be the ones with PPEs and you know, going to these communities. Don't see that happening until, you know, the hospitals have at least more than one mask a day, which is what we have right now.
Yeah, and there's very, you know, strong concern about things like the delivery of TB meds, which are entirely dependent on either facilities being open for daily pickups or for community health workers going out to the community. But if they can't, then we're going to clearly see a worsening and probably a rise in things like drug resistance if people interrupt you know, treatment regimens that are ongoing. So we've come to 1 o'clock. I really appreciate you all being on this call, and the CCDD is really doing some amazing work. Thanks very much, and I look forward to some future meetings like this where we'll know more and be able to share new ideas as things go forward. So thanks, everybody.